Welcome to the Johns Hopkins Medicine online webinar series. Today, Dr. Kristen Petzowski and Dr. Harold Wu will be speaking about myths and misconceptions, understanding endometriosis and uterine fibroids. Before we get started, we like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question. Please check anonymously. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Kristen Petzowski and Dr. Harold Wu to begin our presentation.
Okay, can you see and hear me?
Yes.
Great. All right. Well, thank you so much for joining us today. I think the biggest challenge today is talking about these topics in 15 minutes. But Dr. Wu and I are going to try and get through a brief overview, and hopefully any questions that come in will be able to address any topics that we weren't able to get to in the presentation because it is tough in the time period. My disclosure, I am on the Speakers Bureau for AbbVie. So in my talk today, we're going to talk about endometriosis, define it, talk about the common symptoms, discuss medical and surgical treatment options for endometriosis, and try to recognize the indications and limitations of therapy. So first, what is endometriosis? Endometriosis, yeah?
I think you need to share your slides.
Oh, I thought I am.
I can't seem to see the slides.
Let's see. Let me go back. Up. Here we are.
Oh, perfect.
Okay. We'll just flip through this again. Okay, objectives. Okay, so thank you, Dr. Wu. What is endometriosis? Endometriosis is the presence of endometrial tissue, which we first have to understand what endometrial tissue is. That's the tissue that's normally inside of the uterine lining. So every month you build up the endometrium, you shed that when you have a menstrual period. So endometriosis is where you find that tissue that's normally inside of the uterus, outside of the uterus. And on this diagram here, all these little arrows point to the spots of endometriosis on this picture. So it's that endometrial tissue that's normally inside the uterus is found outside of the uterus. And technically speaking, it's the presence of endometrial glands and stroma. It's a technical definition. Endometriosis is hormonally active, so it responds to the female hormone estrogen. So what that means is that it tends to be active when women are menstruating, and once people become menopausal or by manipulation of hormones with medical therapy, then that should quiet down or make inactive the endometriosis. So where does endometriosis come from? Well, there's different theories as to how endometriosis arises. So the most common theory is what we call retrograde menstruation or backwards menstrual flow. So when you have a menstrual period, we know that most blood exits out of the uterus through the vagina, but we know that people, when women have menstrual periods, some of that blood goes back out through the fallopian tubes. And we know this, if you were to do a laparoscopy, look in someone's belly when they're menstruating, you would see blood in their bellies. And that's very common. We see that all the time. Other theories that can explain endometriosis are we have cells in the body that have the potential to become anything. So maybe a cell in the wrong spot turns into endometrial tissue where it shouldn't be. And also we know that it can spread through vessels and lymph nodes or lymph channels. But all of those theories aren't enough. For instance, that retrograde or backwards menstrual flow, all women have that, but not all women get endometriosis. So there certainly are other factors at play, which we think are environmental factors, genetic factors, because we do more often see endometriosis in families, immunologic factors, so someone's immune system, the way it functions, reasons we don't understand, maybe might make some women more prone to develop endometriosis. So endometriosis is fairly common. It's tough to know the exact prevalence because we'd pretty much have to go do a laparoscopy on every woman, and we're not going to do that. But these numbers come from, for instance, in reproductive age women, we estimate that it can be found in up to 10% of women. And that number is derived from doing laparoscopies in women who were having tubal ligations. And by accident, we happen to see endometriosis in about 10%. It is more common in infertile or subfertile women. So depending on what study you look at, up to 30 to 40%. In adolescents or young girls with pelvic pain, 50 to 60%. And in patients with chronic pelvic pain, again, depending on the study you look at, up to 75%, if not more. There are the common symptoms of endometriosis are pain with periods, which we refer to as dysmenorrhea, pain with sex, which is dyspareunia, pain with bowel movements, which is dyschezia, and then non-menstrual pain, so pelvic pain that occurs outside of the period. Infertility can also be a presenting symptom of endometriosis. And what's fascinating about endometriosis is that we know that some people have no symptoms. So just like in those studies where we were, looked in people's bellies who were having tubal ligations, some of those women had endometriosis and really didn't have any symptoms to speak of. And we see this all the time when we're in the operating room doing surgery for other issues, and we find endometriosis by accident. So the presentation really can be quite variable. And sort of the classic presentation that we hear of is all this pain. Sometimes that doesn't come into play, or people have one episode of pain and then come to find out they have terrible disease on the inside. So really anything is fair game when we're talking about endometriosis. Endometriosis is found in common sites and then some uncommon sites. So the most common sites are the ovary. In this picture, the uterosacral ligaments are not pictured, but those are essentially the ligaments that attach the uterus to the sacrum. The ovarian fossa are not visible in this picture as well. This is a view of a woman from the side. But the ovarian fossa, if you lift up the ovaries, that space underneath. The anterior cul-de-sac is that space between the bladder and the uterus, so where the star is on the screen. The posterior cul-de-sac is that space between the uterus and the rectum. Less common sites that we can see endometriosis are along the vagina, circled there, the cervix, which is the neck or the entrance of the uterus, the rectovaginal septum, which is that space between the vagina and the rectum, and also bowel, bladder, and other places that aren't on here, but along scars. So from like C-section scars, even hysterectomy scars, myomectomy scars in the belly button. And then there's some pretty uncommon sites, which a lot of times, well, we don't see these very often at all, but we know that these sites have, can exist. So in weird places like the lungs, nerves, bone, or other organs. So there's stages of endometriosis, stage 1 through 4. And these stages really refer to the extent of disease on the inside. And what's interesting is that the stages don't correlate to symptom severity. So that means that someone can have one little dot of endometriosis on the inside and they have very little pain they might have severe pain, even given very little disease. And then you can have other patients who have horrible disease on the inside and they have very little pain to speak of. And we don't really understand why. And these are just some pictures of endometriosis. So this is a normal pelvis. This is a picture of someone with stage 1 endometriosis. So if you can see my cursor, the uterus is here. These are uterosacral ligaments. And these are these classic little powder burn lesions of endometriosis along those ligaments. And this is a picture of stage 4 endometriosis. This is the uterus here. And in this case, it's kind of hard to make heads or tails of what is anything because things are so scarred together and stuck. But this is sort of endometriosis here. Everything's just like cement in that pelvis. So how do we diagnose endometriosis? Well, we diagnose it by history and we diagnose it by surgery. So the only way to truly diagnose endometriosis is by surgery and with biopsy, but that certainly doesn't mean that we take every patient that we think might have endometriosis to the operating room. So the first and most important part is just taking an accurate history. And often we'll start treating patients based on that history. But it's important to sort of understand, like, we think you might have it based on all of these symptoms that are classic, but we don't 100% know until we go and do that surgery. So why don't we start with surgery? Well, we don't necessarily have to because of the treatment options, medical and surgical, that we'll talk about, that are equally efficacious or work just as well. So as mentioned, surgical biopsy is required for absolute definitive diagnosis. So these are two pictures of what endometriosis might look like on the inside. And the reason why you actually need biopsy and just doing a surgery and looking isn't good enough is because the predictive value for visual inspection is about 50%. So what that means is if you look at this lesion, and I do endometriosis surgery all the time, and I'm like, that really looks like it. Well, it's about a 50-50 whether I'm right or wrong. Now, there is endometriosis, there's some pictures later on, can be quite variable in terms of its appearance. And some of those appearances are more classic. And you know, if you see that, yeah, most likely it's endometriosis. But some of the more subtle findings sometimes aren't as predictive. So you really do need that biopsy to truly diagnose endometriosis. So what are the treatment options for endometriosis? As mentioned, there's medical and surgical therapy. So the goals of medical treatment are to reduce pain. Most of the medical therapies include something hormonal, which in effect tries to make that endometrial tissue less active, and that's whether that endometrial tissue is within the uterus or outside of the uterus, and reduce inflammation. So what's great about medical therapy is up to 75% of patients report an improvement in symptoms with medical therapy. And the other really important caveat to that is that there's no great evidence that one medical therapy is better than another. So we're going to go through quickly the different medical options, but one is not better than another. One is not stronger, one is not what we can do with that information is that we really can choose whatever medical therapy is going to work best based on your preferences. Cost sometimes comes into play based on insurance coverage, the side effects that you may or may not be interested in, and the duration of use. So if you plan on using it for a couple months and then want to conceive, or if you plan on using it for the next 10 years. The important caveat, though, is that we do know that symptoms often recur upon discontinuation of therapy. So often, you know, treatment of endometriosis is a long-term endeavor. So the first-line medical therapies that we typically use for a treatment of endometriosis, whether that's a known surgical diagnosis or we think it's endometriosis based on symptoms, include things like anti-inflammatories, so ibuprofen, Motrin, any of your anti-inflammatory medications. And these are generally oral in form unless you're hospitalized. And these are really helpful for pain symptoms. We do think that an important component of endometriosis is sort of this inflammatory state. And so anti-inflammatories can help with that. But at this point in time, we don't think that there's great evidence that anti-inflammatories make endometriosis go away. It's just helpful for those pain symptoms. Then the other, you know, typical medical therapies include combined oral contraceptives, which are nice, that come in pill, patch, ring form. These are very well tolerated. They're highly effective. You can use it monthly, so you get your pack of pills, or you can skip that placebo and just use it continuously, so you're skipping periods. And that's really helpful for patients who their main symptom might be pain with periods. You can just skip over and go to the next. There are some certain contraindications for people. So for people who are smokers or age 35, history of blood clots, you have to be careful with use. So you would have to discuss those things with your doctor. Progestins are another type of medical therapy that can be used. So these come in a lot of different forms too, which is great. It comes in pill and injection and implant and IUD. These are very well tolerated, highly effective, and there's not too many contraindications to progestins. There can be some side effects, and the side effects tend to be variable. Some people do great, other people are very bothered. It can include irregular bleeding, weight gain, and some mood changes. The second line medical therapies are things, if you've ever heard of the GnRH agonists or GnRH antagonists, which is gonadotropin releasing hormone. So the common names are leuprolide or elagolix. So these are medications that in our practice here at Johns Hopkins, among our minimally invasive surgeons, we like to know whether we're treating somebody who they definitely have endometriosis or not, just because these medications can have a lot of side effects. So we like to be sure that we know that we're treating the right thing. But these come in injection. The leuprolide is an injection form. The elagolix is an oral form, which is nice because you can easily start it and stop it as opposed to the injection. The big problem with these are that the duration of treatment is pretty limited. So you can only use for 6 up to 24 months. And these can have some menopausal side effects. Now there is sort of a dose-dependent relationship. So for the oral medication, the elagolix, you can start at a low dose, and it's really the minority of patients that can have those side effects, which is nice. But these all have to be used somewhat with some caution because they can lead to bone loss. But you can use these medications along with what we call add-back therapy, so another type of hormone, which can help minimize those side effects. So there are certain indications for surgery. So we typically reserve surgery for patients who failed medical therapy or patients who are actively trying to conceive. So if someone's trying to get pregnant, you're not going to put them on a birth control. Sometimes it's really just helpful to establish a diagnosis. So it might be helpful to guide our therapy if we're not sure if it's endometriosis or some other type of pain condition. Endometriosis surgery, it's not, the surgery doesn't always relate to an improvement in fertility. So a lot of times we will do a surgery in an infertile patient along with decision-making by an infertility doctor. And also often we're doing surgery if we need to investigate a mass, for instance, of endometriosis. So there's sort of 2 broad categories of surgery for endometriosis. So there's a laparoscopy, which is for directed treatment of endometriosis lesion. So this is a conservative surgery. So we're not removing organs. We're doing this just to address those specific lesions of endometriosis of the pelvis. And so there's excision, which means cutting out those lesions, or ablation, which is burning those lesions. So in this picture that we saw earlier, for this type of surgery, we'd just be addressing these specific point targeting those lesions. Hysterectomy is removal of a uterus, which is a very common therapy that we ultimately do for patients with endometriosis. What's important to know is that hysterectomy does not mean menopause. It's only when you remove the ovaries that means menopause. And even in old school teaching for endometriosis, we removed ovaries all the time. But the pendulum has very much swung in the opposite direction, where we tend to minimize that. And we know that patients do very well, with just removing the uterus as a treatment for endometriosis, though sometimes removing the ovaries is indicated. So for hysterectomy, it would be removing the entire body of the uterus, and these days we typically remove fallopian tubes as well. So in terms of ablation versus excision, this is a hot topic these days for the conservative treatment of endometriosis. Again, ablation is burning, for lack of better words, those lesions. Excising is cutting out those lesions. The big benefit of excision is that by excising those lesions or cutting them out, we're able to definitively diagnose and say with certainty that yes, that's what you have. And by cutting it out, it's also great treatment for. There's not a ton of data looking at who does better, whether you burn it or cut it out. The little data that does exist suggests that they're actually equally effective in treating pain. But again, at our institution with our minimally invasive surgery physicians, we have a preference for cutting it out for the purpose of diagnosing and treating. And I'm going to try and speed this up because I'm over. Endometriosis can have quite variable appearances, and I have a few different appearances here. You can have these classic powder burn lesions. You can have these red erythematous patches. You can have sort of these, it look like little vesicles. You can have where sort of the surrounding tissue is scarred and puckered. So the important thing with endometriosis surgery is you have to have someone who does that surgery a lot so they know what they're looking for, because it can be pretty vague in terms of the appearance. So you have to have a high level of suspicion and go after these lesions to get adequate treatment response. So again, a hysterectomy for endometriosis, we consider this for patients who have persistent symptoms, who aren't interested in fertility anymore. And you always want to be sure that you've addressed sort of all possible contributors to pain before going down that road of hysterectomy. You want to combine that with excising all visible endometriosis. And again, removal of the ovaries is not routinely indicated. And that decision, whether you do remove the ovaries or not, is really, it's a tough decision often, because there's a lot of benefits to keeping the ovaries, and most women don't want to get rid of them unless they really have to. So that's a careful decision that's made between patient and surgeon, carefully considering, their case and their desires. And the also important really caveat to hysterectomy is that it's not a guaranteed cure for endometriosis or pelvic pain. And we know that up to 30% of patients can continue to have persistent pain, and up to 15% can have persistent or new pain. And then I would be remiss if I didn't mention there's some other types of endometriosis that we just don't have the time to get into today, but there's, specific to ovaries, we can see endometriomas of the ovaries. You can see deeply infiltrating endometriosis, which is these big lesions of endometriosis. You can have endometriosis of incision, so especially like after C-section or previous GYN surgery, and adenomyosis, which is sort of like a form of endometriosis, but it's like endometriosis within the muscle wall of the uterus. So the take-home points here is that endometriosis is the presence of endometrial tissue outside of the uterine cavity. It is hormonally dependent. The symptoms are quite variable and can even include no symptoms at all. Symptom severity does not correlate to the extent of disease on the inside. Endometriosis is only diagnosed with certainty by biopsy, and it is effectively treated both with medicine and with surgery. There are many options for treatment. There is not one single option. If you're given one single option, go get some more opinions. There's no medical therapy that is superior to another, so we really can choose it based on patient preference. Surgery can be too conservative, keep treating just those endometriosis lesions, or something more radical like removing the entire uterus or anything else that might be affected. Importantly, hysterectomy does not mean menopause, and all decision-making really should be shared between patient and the provider. And then again, we don't have time for this last important point. That's a whole nother talk altogether. Not all pelvic pain is endometriosis. So you do want to see somebody who can importantly guide you through all other causes to be sure that we're not doing something like hysterectomy and removing the ovaries when your pain isn't from that. So that's an important point as well. So we'll get to questions. Thank you very much. We'll get to questions after Dr. Wu goes through his presentation. I'm sorry for running over Dr. Wu.
Not at all.
He talks a lot faster than I do.
All right.
Thank you.
Let's see. I'm going to share my screen. All right, hello everyone. Thank you for taking your time to join us today. As Amy introduced earlier, my name is Harold Wu. I'm one of the minimally invasive gynecologic surgeons here at Hopkins, and as my part of the talk, we'll be working more towards understanding uterine fibroids. I have no relevant disclosures. So as a brief outline, we're going to answer several important questions. Start at the basics. What are uterine fibroids? How and why do fibroids occur? What are the symptoms of fibroids? How do we actually diagnose them? And perhaps more importantly for everyone here, what are the available treatment options that we often talk to patients about? To start, basically, fibroids are non-cancerous growths of the uterine muscle layer, or the myometrium. To orient everyone to this picture here, I think you can see my cursor. Right here we have the vagina going into the opening, the cervix, that's the opening of the uterus. And then here's the muscle layer with these fibroids, or these little white blobs. Then you have your tubes coming off on both sides and the ovaries next to them. The fibroids are most commonly, they're the most common pelvic growth in reproductive age women. Up to 80% of women will have fibroids at some point in their lifetime, but that does not mean that everyone will have bothersome symptoms. And we'll get into that a little bit more later. The exact cause of fibroids is unknown. Risk factors that we've studied before include race. They are more common in Black women. Family history does have something to do with it, so genetics plays a role. Earlier onset of periods, no previous pregnancies or births. We do know that fibroids are growth responsive to female hormones like estrogen and progesterone, but it's really difficult to predict growth over time. If we had a crystal ball for that, we'd all be very wealthy. But they do tend to shrink or stay about the same size after menopause. Before we get into more of the nitty-gritty details about symptoms and treatment, it's important to kind of talk about how we discuss fibroids clinically, and that has to do with the anatomy. So fibroids can be classified in different categories based on where they are, and that can alter their symptoms. So submucosal fibroids, as you can see here, are the fibroids that are close to the lining of the uterus, which is what sheds every month with your period. They can even be pedunculated or intracavitary, meaning they're almost entirely inside the womb or the cavity of the uterus. Intramural fibroids are those fibroids that are purely inside the muscle layer of the uterus, and subserosal fibroids are those that are more on the outside layer of the uterus. They kind of bud out. Some are even pedunculated, or like Mickey Mouse ears. It can give your uterus kind of this irregular shape sometimes. When we think about fibroid symptoms, they often can be classified into different categories. The three common categories, just for ease of thinking, is bleeding issues, or bulk-related symptoms, or even fertility concerns. Really, one of the major take-home points today is that the symptoms really depend on fibroid size, number, and location. So not all fibroids are the same. You may have different symptoms or no symptoms at all. So every patient's unique fibroid leads to the specific symptoms for her, which is very important when we actually talk to you about the optimal treatment and counseling. So let's start with bleeding. Submucosal intramural fibroids tend to be responsible for those, and I've highlighted them here. As you can see, the ones that are closer to the lining can then really mess up periods because that's where your period flow comes from. And even large intramural fibroids that deviate the lining or make the cavity larger can do the same thing. This tends to come out as heavy or prolonged menses, passage of clots, staining of clothes, and unfortunately can even lead to iron deficiency anemia if it's severe enough. For bulk symptoms, that's usually from some serosal fibroids, and then also the overall number and size of fibroids. If it's very enlarged, for example, you could have different types of fibroids, but they make your uterus very big and bulky and irregularly shaped. That can lead to pelvic pressure and can also press on nearby organs like the bowel and bladder and lead to urinary frequency or even constipation. As for fertility concerns, not surprisingly, those fibroids that distort or affect the uterine cavity where the womb is, right? So submucosal fibroids or even some intramural fibroids that kind of deviate or cause shifting of the cavity, that can affect fertility. Subserosal fibroids do not impact fertility. I also have this caveat here that fertility is based on multiple factors such as age, medical history, partner fertility, and it's impossible to really say exactly what percentage of fertility or infertility is due to fibroids. A lot of women have fibroids, get pregnant without problems, and so you really need both the discussing your fibroids with a surgeon, a fibroid specialist, and a fertility doctor if that was a real concern. Dysmenorrhea, or very severe pain with periods. Patients do tend to have more menstrual pain when you have heavy flow or passage of clots. As you can imagine, your uterus is trying to cramp and pass out those clots, but severe pain is not commonly from fibroids alone. And so you do want to consider other conditions such as adenomyosis and or endometriosis that Dr. Petskowski just talked about. We diagnose fibroids most commonly through exam and imaging. Oftentimes patients will have some concerns on history, or on exam will feel an enlarged uterus concerning for fibroids, and pelvic ultrasound is the initial imaging modality that we use. It gives you this general survey. It tells you, where your fibroids are, how many there are in general. And then as surgeons, we really do love pelvic MRIs. They are very good for really accurately depicting all of your fibroids in terms of size and location. It really helps us figure out how to counsel and optimize your care to make your symptoms improve. So in terms of management, your treatment plan really depends on, as we say again, the size, number, location of fibroids, your specific symptoms, whether or not there's a desire for future fertility, and of course your personal wishes. If you have fibroids but don't have symptoms, it's still important to know that and follow with a primary gynecologist or one of us, or with your primary care doctor. And depending on the size, the location, and also your plans for family in the future, you may want to follow that with routine ultrasounds. So the first category of management that we often talk about is medical management, and that usually is in the form of hormonal therapy, or what a lot of people know as birth control. These come in various formulations: pills, patches, injections, implants, IUDs, all with their respective benefits and side effects. But really the point is to suppress your cycles, to kind of stabilize that lining where the fibroids may be disrupting and improve flow of your menses. It does not reliably reduce fibroid size over the long term, so it does not improve bulk symptoms. Again, not for everyone, and it's not for patients who are trying to get pregnant. Symptoms do typically return after stopping hormonal therapy. There's one caveat: depo-lupron or leuprolide acetate, which Dr. Paskowski mentioned briefly in her last presentation. It does bring on a temporary menopausal state with its own side effects of hot flashes, night sweats, kind of like being in menopause. And it does reduce your fibroid size by about 50% over 3 months, but you can't use it for a prolonged time due to side effects. Bone loss example for being a severe example, and expensive medication as well. And it's usually used in the short term before surgery to improve blood count if you're severely anemic, or to reduce the size of the uterus prior to surgery. Symptoms typically return after stopping hormonal therapy. Uterine artery embolization, some of you may have heard of. It's a procedure, not a major surgery. The procedure is done by interventional radiologists. Basically, they thread this catheter under sedation, either through the wrist or the groin, and they track their way to the vessels that feed the uterus and the fibroids and block them with sterile beads. This reduces fibroid size by about 50% over 6 to 12 months. It does improve bleeding and bulk symptoms, but it is not recommended for patients who want to have children, because we don't have long-term rigorous data about what actually happens to the uterus and how that affects fertility and pregnancy outcomes when you do block all that blood flow. Some good considerations is that it does avoid a surgical procedure. That can be a very important personal preference for some patients, which is important, but it may also be better for patients who are just too high risk. Their health places them at high risk for surgery. Some considerations to think about, though: not all fibroids are good candidates. So we often send patients who are interested to our interventional radiologists for a full consultation to make sure that the fibroids will respond appropriately to this kind of treatment. Regrowth of treated fibroids or growth of new fibroids are always possible, so you may have return of symptoms, and about 20% to 30% of patients will need further fibroid treatment, and some will need a hysterectomy to continue to manage those symptoms. I want to say a few brief words about these two procedures slash minor surgeries that has come to the forefront. The Accessa procedure is a relatively new procedure. Essentially, it's a laparoscopic or small incision done in the operating suite, a laparoscopic surgery, and the surgeon will inject this array using an instrument into the fibroid that heats the fibroid up and pretty much melts the fibroid so that it shrinks over time. A lot of patients do get good symptomatic benefit for both bulk and bleeding symptoms. Because it's relatively new, we are trying to get that available at Hopkins. It's not here yet, and we're having working with insurance companies as well. Some of them don't cover that just yet, given the novelty of the procedure. MR-guided focused ultrasound is another option for some patients. Essentially, you sit in an MRI machine where they map the fibroids, and then there's a plate with ultrasound waves that kind of emit high-intensity beams of sound to heat and ablate and melt those fibroids. It's a little limited in what kind of fibroids can be treated. As you can imagine, it should be fibroids closer to the front of your uterus. The size needs to be somewhat moderate. And there can't be too many fibroids. You definitely don't want to be, heating beams of ultrasound through organs or through your entire uterus. So there are some limitations to that modality. And then finally, surgery, the first form of which is myomectomy, meaning just removing the fibroids. There are different ways to remove fibroids, and the route depends on the size, number, and location. So hysteroscopic, or the vaginal approach, right, which is where we remove fibroids that are mostly in the cavity. Laparoscopic robotic are small incision approaches from above through the abdomen, and open, like a larger incision, again, depending on the fibroid burden. This allows for more immediate relief of bulk and bleeding symptoms. And it's really for patients who desire future pregnancy, who do not want to remove their uterus. You want to consider the possibility of requiring a C-section for future pregnancies. So even though we do, try our best to make sure that we secure the fibroids and then suture up the uterus so it heals well, the integrity may not be the same. So we want to avoid putting those uteruses through labor if there are lots of large incisions, because we don't want your uterus to break open during labor. That can be very catastrophic. Growth of new fibroids with time. So obviously these surgeries don't prevent new fibroids from happening, and it may not be possible to remove all fibroids. There are very tiny little fibroids with no symptoms, we don't want to make 1,000 cuts on your uterus because that could do more harm than good. And then finally, for hysterectomy, that's removal of the uterus and fibroids. Again, as Dr. Paskowski mentioned, that does not equal menopause unless the ovaries are also removed, and that really just depends on patient's preference and also any other ovarian issues. This is the only method guaranteed to remove all fibroids and prevent new fibroid growth. And it's only for women who are finished having children or do not want children in the future. There I show removing the uterus and the tubes and keeping the ovaries. So take-home points, fibroids are benign growths of the uterine muscle. About 80% of women will have them, but not everyone will have symptoms, and the exact cause of fibroids is unknown. The growth of each individual fibroid is difficult to predict over time. The symptoms are based on size, number, and location of fibroids, abnormal bleeding, bulk-related symptoms, fertility concerns, and it's not typically associated with severe cramping during periods. Pelvic ultrasound and MRI are useful imaging for diagnosis as well as treatment planning to make sure we optimize your outcomes. And again, the optimal treatment plan is really dependent on the fibroid burden and symptoms and family planning goals. Options for women who want future fertility are hormonal therapy or myomectomy. Uterine artery embolization is a useful option for those who wish to avoid surgery or who are too high risk for major surgery. Hysterectomy is the definitive management for symptomatic fibroids. And remember, after menopause, most fibroids slightly decrease in size, but they don't disappear, but symptoms tend to improve because the cycles that affect your periods are no longer happening. So I think we've reached the end of our presentation. So I will stop screen sharing. Go. So our first question, I guess I'll just get us started. Can endometriosis or uterine fibroids cause abnormal pap smears? That is not something that we typically see between the two associations. They're technically different conditions. So the short answer is no.
And then the second question, I guess it depends if we're talking, one of the questions was, are there other natural holistic solutions that don't involve birth control pills or surgery? And that depends if we're talking about endometriosis or fibroids. I can tell you there's a lot of interest in this, and there definitely are some studies ongoing. The only alternative therapy that has been shown to be helpful in treating, statistically significantly helpful in treating pelvic pain associated with endometriosis is acupuncture. So again, that's been shown to be effective in treating pain. It hasn't been shown to like make endometriosis go away. There's definitely a lot of interest these days in like anti-inflammatory diets for both endometriosis and fibroids. And I think it's great in theory, and I would never stop someone from doing it because those diets have a lot of other potential benefits. But the reality is that we're still a little behind on the scientific end of things, showing that those can be helpful for endometriosis or fibroids.
The third question, is it difficult to tell whether something is a fibroid versus a mass of cancer? The short answer is yes. It does depend a lot on what we see. So, overwhelmingly, fibroids are benign growths, but there are some risk factors for when fibroids can turn into cancer. For example, when we do an MRI, if the MRI shows that the fibroid has different signals, meaning it, I guess the easy way to explain it is it just looks different or aggressive or has different patterns based on the contrast and the flow of blood vessels. And oftentimes we'll work together with a radiologist to see if that looks different, then we may be more concerned it may be a mass of cancer. It tends to happen more in fibroids that grow quickly, although that needs to have a caveat of its own because fibroids that are benign and just normal can also grow quickly. So it's very difficult to actually piece that all together. Women who are older, of course, as with all other types of cancers, can have higher risk for cancer. So really, if a patient does come in with a concern that their fibroid might be an abnormal mass or cancer, we do work very carefully with our radiologists. We do biopsies of the lining of the cavity to make sure there are no other abnormal cells. Of course, when you do that biopsy, you're not actually sticking anything into the fibroid itself, so it's impossible to tell exactly what that is. But we are very careful if we have any concern for abnormal cells. that we come up with the appropriate plan for you. So I guess short answer is, if there's a concern, come see us. We could talk to you a lot more about that and how to work that up.
I would say that one important point, though, is that the risk of what appears to be a fibroid being a cancer is actually incredibly small. So far and away, a fibroid usually is a fibroid. There's a very small risk. The numbers are a little bit all over the place. The worst number you ever see is 1 in 350, but it's probably a risk of more like 1 in thousands that would be the case. So most fibroids are benign fibroids. There's a question about what are potentially some treatment options for chronic leg pain due to endometriosis. So I think that would definitely require an evaluation and an exam. If endometriosis is causing leg pain, that would be one of those pretty uncommon presentations of endometriosis that is definitely possible, but pretty rare, and potentially could be, if that were the case, is that involving nerves, which again is a very rare presentation of endometriosis. So I would definitely want to make sure that whatever patient has been really fairly evaluated for that and for other possible causes of pain.
Okay, and then could surgery around your ovaries impact fertility? I think I'll let Dr. Piskowski take that one since she did the endometriosis talk. Is that, I'm assuming that's more related to endometriosis.
Yeah, so that it depends. It depends what you're doing. And if you were to have a cyst of endometriosis of the ovary, that can impact the ovarian function. So we're always very cautious, especially in a woman who desires future childbearing. There are definitely some considerations that you want to take intraoperatively to try and preserve ovarian function. Like, you don't want to burn the ovary. You want to gently do a dissection. You don't want to, often you want to preserve the ovary and not, sometimes people will be given options of removing a cyst or removing the entire ovary. The vast majority of time you're able to remove just the cyst itself. And then there's, you just want to treat the ovary cautiously. Don't burn, use sutures if you need to, use different agents that you're not traumatizing the ovary, because yes, potentially it can impact ovarian reserve, which potentially could down the road impact fertility. But the answer is a little bit complicated, but yes, you want to treat the ovaries gently, and we do always take that into consideration when we're operating. And then someone asked, is it possible to have endometriosis on the abdomen or belly button after myomectomy? Yeah, we see endometriosis in incisions. The most common is after C-section, so a long C-section scar, but you can see it after laparoscopic surgery, so at laparoscopic port sites. You can actually see endometriosis sometimes in a patient who's never had surgery. You can see it in the belly button. And that's one of those theories as to how it arises. We know that sometimes it can just come from a cell that has the ability to become anything. So yes. Someone else asked about what are the names of progestins to treat endometriosis. Well, there's actually a lot of different progestins. It depends on what form. So the answer is kind of big to that. One that we often use is norethindrone. You can use medroxyprogesterone. You can use levonorgestrel. What am I forgetting, Dr. Wu?
The implants can
oh, right. I'm forgetting the
implants, etonogestrel.
There you go.
And that kind of leads into the next question: is Mirena IUD an effective method to manage endometriosis? It certainly is. It is one of the great benefits of having low maintenance, and it does gently elute hormone into the pelvic region. It has very few side effects systemically, and so it definitely can be an effective way to suppress your cycles and manage endometriosis.
And studies have been done showing that it, again, with medical therapy, nothing is superior to another. So it has been shown to be equally effective to other methods. And it's nice because, it is there. It's good for 5 years if you do well with it. Great. And all of the progesterone releasing IUDs are potential options.
Define the diagnosis: fibrocystic ovaries. I have to say,
I think maybe the question is about polycystic
Polycystic?
ovaries, not fibrocystic ovaries.
Hmm.
We can often see fibrocystic breasts,
Yeah.
but it's maybe polycystic ovaries, but that's a different issue altogether, not so much related to fibroids or endometriosis. But briefly, that's where you have lots of little follicles. Often women have difficulty ever recruiting one of those follicles to ovulate, and often women will have infrequent periods, excess hair growth, acne, but that's a separate issue from those we discussed today.
Do you see a connection between uterine issues and breast cancer? Does one raise your risk for the other? That is generally a very loaded question. It's a little complex to answer. The short answer between uterine issues and breast cancer for the general population is no. There are specific familial genetic syndromes, for example, BRCA or BRCA mutations, that increase a patient's risk of breast cancer. Depending on the type, you can also have an increase of ovarian and uterine cancers. But let's say you have fibroids or endometriosis, that doesn't necessarily do anything for, if you're a normal baseline population, do anything for your breast cancer risks. What about acupuncture for fibroids? Again, there's very few logistical studies that have done high quality, rigorous trials for that. So off the top of my head, I can't say, and Dr. Miskowski, please chime in as well. I can't say there are any trials I can remember that do that specifically for growth of fibroids or fibroid symptoms. But again, acupuncture does help with a lot of people's lifestyles and stress and everything in general, and that can certainly improve your life, so I never say no. Is there anything that will help shrink them beyond just pain relief, but get rid of them? As we discussed, there's nothing that reliably shrinks them in terms of a medication or a pill. The ways to manage and decrease volume or remove them is really through procedures or surgeries.
There are potentially some medications
like
coming down the pike.
Yeah.
No, the progesterone receptor modulators. There's some trials that have somewhat been put on hold, but maybe in the next, in the next couple years, we will see some medications that can be used for short periods of time that can shrink fibroids. But yeah, as Dr. Wu mentioned, right now we're kind of have procedures or surgeries to do that. Are there any risks of getting pregnant if one has endometriosis? Not really. You know, and other important point that often comes up is endometriosis is definitely associated with infertility, but endometriosis does not equal infertility. So just because someone has endometriosis doesn't mean they can't get pregnant. In fact, the vast majority of people do. So the only way to test fertility is to try and get pregnant. And what's interesting about endometriosis too is that, you know, the stage of disease doesn't necessarily correlate to infertility either. So there's not really risk of getting pregnant if one has endometriosis. Now, potentially, you know, if somebody has scarred tubes from endometriosis, that could potentially increase the risk of an ectopic pregnancy, but that's a pretty uncommon scenario. So the general question, there's some caveats, but in general, no, there's not risk. And in fact, pregnancy is a great treatment for endometriosis because of the hormonal changes that actually quiets down endometriosis. So pregnancy is good for endo, as is breastfeeding afterwards.
The next question, if IUD is expelled out in 6 months due to fibroid disorder uterus, is it safe to replace it? I would say it's not unsafe to replace it, although you should be thoughtful along with your care provider whether that might not be the best option. If the lining of your uterus or the cavity is really that distorted where the IUD actually gets expelled and falls out, may not be that good for managing your pain. You might want to think about your fibroid size, location, and other therapies that we talked about.
You might need to remove a fibroid
to make it better to put an IUD in. Yeah.
Yes.
Is there any correlation? Oh, Dr. Petskowski, that's all you.
Is there any correlation between egg quality and endometriosis and uterine fibroids? So there is no correlation between egg quality and uterine fibroids. Is there any correlation between egg quality and endometriosis? So there's a little bit of a difference between endometriosis and then there's endometriomas of the ovaries. And endometriomas of the ovaries is sort of a very specific type of endometriosis, which we see in the minority of patients. So only 20 to 40% of patients with endometriosis will have endometriomas or cysts, those chocolate cysts of the ovaries. And there is some thought that if someone requires IVF, in vitro fertilization, that potentially, you know, it's not even egg quality, but potentially if that egg is in the presence of that endometrioma fluid, that potentially could impact egg quality. But there's a lot of big question marks around that, and we don't totally know. We do know that sometimes patients who have endometriomas of the ovaries have impaired ovarian response, meaning that if you stimulate someone's ovaries in effort to remove eggs for IVF purposes, they don't respond as well as someone who doesn't have endometriomas. But there's definitely some questions about egg quality. But we do know that patients who have endometriomas of the ovaries, not all comers endometriosis, but endometriomas of the ovaries sometimes do not respond as well to ovarian stimulation. And there's another question about endometriosis causing abnormal pap smears. No, abnormal pap smears are from the vast majority of time HPV, human papillomavirus, which is unrelated to endometriosis or fibroids.
Is there any recommendations on how to overcome the fatigue associated with endometriosis? In general, if there is a lot of fatigue that's part of your symptom profile for endometriosis, you might want to think about other diagnoses as well that might be leading to added fatigue. But other than actually treating the disease itself, there's no specific therapy or surgery or pills per se that actually targets that particular symptom. And we want to be thoughtful if we're looking at the whole picture, right? So if you have a lot of fatigue, it may not just be endometriosis. And I would say oftentimes we want to caution our patients that there are a lot of things you can read online where endometriosis can lead to a ton of different things. And it is true, it is possible endometriosis can go to a lot of different organs and cause a lot of different symptoms. But we want to be thoughtful about whether we're looking at the whole picture, if there are other symptoms that just don't quite feel right or fit with the picture, that we're taking care of everything that we're worried about and not just blindsiding ourselves to one diagnosis.
There's another question. How closely is endometriosis related to ovarian cancer and IBS, irritable bowel syndrome? Okay, so the ovarian cancer issue is a very interesting one. There are some studies showing that in patients who have endometriosis, and especially endometriosis of the ovaries, that if that patient were to develop ovarian cancer, it is more likely to be a certain type of ovarian cancer. So there's an increased risk of what's called clear cell or endometrioid and ovarian cancer. It is not clear if patients with endometriosis have an increased risk of ovarian cancer. So the studies are a little bit conflicting, but what is clear is that if someone does develop ovarian cancer, there is an increased risk of these certain types, clear cell and endometrioid. So the other question is endometriosis related to irritable bowel syndrome. So irritable bowel syndrome is a functional problem of the bowel where patients often can have pain associated with bowel habits, diarrhea, constipation. And we do often see those conditions occurring together. Endometriosis and irritable bowel syndrome, we often see painful bladder syndrome or interstitial cystitis, high tone pelvic floor, a lot of conditions that we often see along with endometriosis. And it's not that endometriosis causes IBS or IBS causes endometriosis, but we think that both of those conditions often have an inflammatory component. So if things are inflamed in general, whether that's your bowel flared up and then that inflammation led to sort of a flare of endometriosis pain or vice versa, it's not clear, but we do definitely see those conditions coexist. We also think that there's something called central pain sensitization, which is where in some patients with multiple pain conditions, studies have shown that there's actually some changes in the nervous system where patients have begun to interpret normal stimuli as painful stimuli because of those changes in the nervous system. So just the bowel moving along in the belly, which it always does, the nervous system is suddenly interpreting that as a painful type of event, or just, you know, uterine cramping with a period suddenly is interpreted as a severe pain event. And so that's another thing that is a little complicated, but we do see this phenomena called central pain sensitization that often links a lot of these chronic pain conditions together.
Could my fibroids come back after treatment? They certainly can. It really depends on the kind of treatment you've had. So for example, after a hysterectomy where you've definitively managed them, no, because you've resolved the fibroids. But if you've had a myomectomy, if you've had a procedure like uterine artery embolization, new fibroids could grow, and old fibroids that were previously embolized or shrank could grow in size as well. And again, as we mentioned, medical therapy doesn't actually get rid of any fibroids or reliably shrink them over long terms of time. So that certainly can happen as well.
And there's another question, are endometriosis patients more likely to have anemia? So it kind of depends on the type of endometriosis that you're talking about. For sort of superficial mild stage endometriosis, no, we don't more often see anemia in those patients. Sometimes when patients have pretty severe extensive disease on the inside, or for instance, adenomyosis, which is thought to sort of be like the cousin of endometriosis, where people have a lot of heavy, or that's endometrial tissue within the wall of the uterus, patients often will have heavy bleeding associated with that. So sometimes you do, but for probably the majority of endometriosis, no, we don't see, you know, severe anemia, but we certainly can, depending on the type of endometriosis disease that a patient may have.
The next question, how do fibroids develop and navigate through or during perimenopause and or menopause? That's a great question. So the million-dollar question of why fibroids exactly occur, we are not quite sure, but we do know that they are responsive to female hormones like progesterone and estrogen, so with cycles. So in reproductive age women, fibroids can grow over time. And through perimenopause, again, your cycles are still occurring, although you're entering that menopausal transition phase, patients could still have very symptomatic fibroids with heavy bleeding, if that's where their fibroids are located closer to the cavity, for example. But as you kind of transition through menopause, in terms of the bleeding symptoms, they should abate and improve and eventually resolve as you enter menopause, because fibroids tend to shrink a little bit or stay about the same size. And don't really cause any issues with cycles as your cycles kind of stop with menopause. There's one caveat to that in terms of bleeding symptoms. There are some fibroids that are very much in the cavity or against the cavity, called submucosal, as we talked about. So even in menopausal patients, some of those fibroids can cause some irregularity or inflammation in the uterine lining and may cause some postmenopausal bleeding, which is a whole separate topic, but needs to be discussed and worked up with your gynecologist as well. In terms of bulk symptoms, right? So if you have a lot of fibroids and they're big and your uterus is bulky and you have a lot of pelvic pressure after menopause, that isn't going to change tremendously. The fibroids may change a little bit, decrease in size a little bit, but if you have a large fibroid, for example, and you feel like you're always 6 months pregnant, and sometimes you do have large fibroid uteruses like that in our patient population, that would not necessarily improve a lot with menopause. So really it depends on, you know, your fibroids and your symptoms as well. Can poor tampon usage cause endo or fibroids? In terms of fibroids, no. And I guess I would first have to clarify what poor tampon usage means. But generally, I would say no to both. Dr. Piskowski?
I would generally say no to both too. I don't know if there's like a thought that, well, I think there's two schools of thought, like it maybe that's forcing more retrograde menstruation,
yeah.
But it typically will just find its way out,
Yeah.
and not go back. And then I think there's also some thought that maybe sort of chemicals that are in tampons might be related to endometriosis or fibroids. I think it's definitely an interesting topic, and there potentially is an element of we just don't know. Is it possible? I suppose so, but right now there's not any data that would suggest that tampons are related to endometriosis or fibroids.
if you have endometriosis and have had a hysterectomy but still have chronic pelvic pain, what type of doctor should you see? You should see us. You should see a patient. Those of us who actually see pelvic pain a lot, we don't just manage endometriosis or fibroids, we manage other things involved in pelvic pain. For example, a common thing that is sometimes missed, and I'm sure Dr. Petzkowski will agree, is something called pelvic floor dysfunction, or just painful muscles of the pelvic floor. And surgery can't cure that. And oftentimes we see patients who have a hysterectomy for that, and they do feel a lot better because their cycles, their cramps, their endometriosis like pain is gone. But then there are other things that we need to take care of as well. So come see us.
Agree. As Dr. Wu mentioned, there's 4 of us here who specialize in minimally invasive surgery, and we all treat endometriosis, and we all treat also pelvic pain. And it is very common. You have to address all possible causes of pelvic pain, not just endometriosis, because it's often multiple things that are contributing to pain. So there's a lot of possible things that could be going on, but we definitely see and treat those patients regularly.
Why do fibroids impact Black women more?
Great question.
I wish
we don't know.
That. Until we do have reliable gene mapping and genetic testing, which is way off in the future, we can't answer that exactly. We just have studies that help us figure out the epidemiology of things.
And we don't know. We don't know why some women develop 1 fibroid and other people will develop 50 fibroids. We do not understand. We have a great research department here at Johns Hopkins with one of our faculty who is doing a lot of fibroid and endometriosis surgery. So Dr. James Seegers is a really great, he's been here for several years, but he is a great person to have on board, and hopefully with his work and the work of many others in the world, hopefully we'll be able to get to the bottom of that someday.
Mm-hmm. I think that's our last question.
Thank you all so much for joining us today.
That's it. All right. All right.